Hello, thanks for the introduction, Greg. And it's really an honor and privilege to be here in person and seeing so many patients out in the audience. And I know there are many patients listening online as well. So really appreciate you coming to this myeloma crowd meeting today. So today I'm going to be talking about pragmatic treatment strategies in multiple myeloma over the next 20 to 25 minutes. These are my disclosures. So basically over the next 20 to 25 minutes, I'll be briefly talking about the current myeloma treatment landscape. And then I'll kind of segue into what are the key considerations as a myeloma physician that I like to discuss with patients in terms of choosing the right treatment for you. And finally, I'll be talking a little bit about some of the more granular details of some of the new treatments available for multiple myeloma, including antibody-drug conjugates, CAR T therapies, and bispecific antibodies. So if there's one take-home message I want you to take today is that there's been incredible progress in the treatment of multiple myeloma over the last 15 to 20 years. We had very limited treatment options back in the 1980s and 90s for multiple myeloma. But really, over the this really started in the early 2000s with the developments of protease inhibitors like bortezomib, approved in 2003, and immunomodulatory drugs such as lenalidomide in 2006. You can see that there's been a whole host of drugs approved during this period of time. In particular, the last 2 to 3 years have been particularly busy for the myeloma treatment landscape with the approval of the first BCMA targeted therapy, belantamab mafodotin, the first antibody-drug conjugate for multiple myeloma, and more recently, the first CAR T therapies approved for multiple myeloma with idacatrin viclucil and sulticatrin autoleucel. And there are additional future drugs just around the horizon. So these are things like bispecific antibodies targeting BCMA, GPRC5D, and SHR5. There's new CELMoDs, or essentially next generation IMiDs, next generation essentially drugs that are similar to lenalidomide and pomalidomide, and other small molecules such as BCL2 inhibitors like venetoclax. So another helpful way to think about myeloma drugs is the different classes of myeloma drugs. And so we can separate myeloma drugs based on different classes, such as alkylating agents, protease inhibitors, immunomodulatory drugs, monoclonal antibodies, antibody-drug conjugates, CAR Ts, and XPO1 inhibitors in the case of selinexor. And we can oftentimes use terminology to help define certain patient populations with multiple myeloma. So one of the really unmet needs in myeloma about a decade ago was something called double refractory multiple myeloma. These are patients who are refractory to protease inhibitors and immunomodulatory drugs. And actually, about 9 years ago, actually, Dr. Orlowski, Dr. Shaw, and myself, we wrote a paper, a review article about what's the optimal way, what are some of the new approaches to treat double refractory multiple myeloma. And this was actually in the 2013 ASCO education book. I'm really happy to say that this paper is completely obsolete. It's just a historical record of how we treated myeloma in 2013. This really speaks to the fact that the field has changed so rapidly. And now we often use this term called triple class refractory. This is sort of the current challenges in myeloma, where these are patients who are refractory to immunomodulatory drugs, protease inhibitors, anti-CD38 monoclonal antibodies. And fortunately, just with some of the recent drug approvals, we have now new therapies that address this particular unmet need. So another way to think about myeloma is in terms of combinations of therapies as well. And so we rarely treat myeloma with a single drug. We have noted and we have seen many studies where treating drugs in combination is much more powerful and more synergistic than treating myeloma with a single drug. So you can see there's, among all these drugs that are currently FDA approved, there's multiple permutations of how we can combine these drugs as well. And so actually currently there's what we call 14 category 1 or highly recommended, we call NCCN1 recommendations in patients with at least 1 to 3 lines of prior myeloma therapy. So the bottom line is that there are many options for treatment. The myeloma treatment landscape is admittedly very, very complicated. It's a full-time job for me to keep up with all the updates with multiple myeloma. Every 6 months, there's a new congress with new data. And essentially, we as myeloma session, we live and breathe myeloma. And I don't know if that's a good thing or a bad thing, but that's what we do as a living, is really want to assimilate this information rapidly and provide this information to you as patients. And so, myeloma in 2020 was sort of, everyone got the same thing. This is the school cafeteria lunch, essentially. And if you didn't like cheese pizza and macaroni and cheese, well, tough. We had very limited treatment options in 2020. And Myeloma 2022 is sort of like a Cheesecake Factory menu. I don't know if you've ever been to the Cheesecake Factory, but it's very overwhelming when I go there. It's like there's too many options in the menu. How are we going to think about myeloma treatments? And so, as I mentioned, we're really trying to simulate this information in real time, when we're seeing patients in the clinic. How are we going to choose different treatment options for patients? And so one of the broad categories to think about are disease-related factors. And so I tell patients, not all myelomas create equally. There are some myelomas that are more aggressive than others. This is largely dependent on some of the genetic studies that we do. When we do bone marrow biopsies on myeloma patients, these are called something called the FISH studies or cytogenetics. And so if patients have some certain types of myeloma called high-risk myeloma, which are more aggressive, we may tend to be more aggressive with certain treatment phases with the myeloma versus less aggressive myeloma. We also consider the type of myeloma presentation or the type of relapse. There's a term we use called biochemical relapse or biochemical progression. This is where the only thing that's really going on that's showing that the myeloma is growing is based on the lab markers. So the M protein might be slowly trending up. There are no other clinical signs of myeloma progression. And other patients may develop new bone lesions or may have kidney failure. There's a much greater urgency to treat rapidly in such patients who are having clinical relapse, perhaps more aggressively as well. The other thing to consider is the duration of response to prior therapies. So if a patient has had short responses to prior treatment regimens, we want to be potentially more aggressive with subsequent treatment regimens. And so the duration of prior response matters as well. There are regimen-related considerations as well. So certain drugs have certain toxicities, well-known toxicities, bortezomib or Velcade. One of the associated side effects is well known as neuropathy. A drug called belantamethasone, the first-in-class BCMA antibody-drug conjugate that was approved, can cause ocular toxicity or irritation of the cornea. We also consider prior drug exposures, what the patient's been exposed and treated with in the past. And finally, there's always the option of standard of care versus clinical trials. You heard a lot from Dr. Orlowski earlier this morning, how we really advocate for clinical trials. This is sort of near and dear to my heart, as we are all involved with clinical research here at MD Anderson to really pioneer the next sort of generation of promising myeloma therapies. So I'd encourage everyone in the room, when they're considering sort of different treatment options at each sort of key point in their myeloma journey, to consider clinical trials in their treatment options. And there's also patient-related factors as well. I think what you think and what your preferences are matters a lot. And so some patients may prefer oral therapies given their lifestyle. And so, now that we have many options for myeloma, there's treatment options that are all oral that we can consider for patients. For some patients, intravenous therapy or subcutaneous injections aren't an issue. And so there's different factors to consider there. Age and comorbidities, and a general term we call performance status, or just the general health of a patient matters as well. So we have to consider really towing the fine line of balancing efficacy with quality of life. And I think we can achieve that with some of the therapies that we have in myeloma today. So in the next sort of 5 minutes or so, I did kind of want to drill down a little bit more on some of the granular details of some of the novel treatment approaches in multiple myeloma today in 2022. And so I listed here antibody-drug conjugates, chimeric antigen receptor T cells, and bispecific T cell antibodies. And the reason why I mentioned this is that, as you may know, there's a new target in myeloma called BCMA, B cell maturation antigen. And now there's a lot of therapies targeting BCMA using these different therapeutic modalities. And so the first is something called an antibody-drug conjugate. And so basically, this is basically an antibody that is basically targeting a protein on the myeloma cell. In the case of belantamethasone, it's BCMA. And essentially, it's tethered to a toxin, a chemo, essentially. And essentially, the first step is that the antibody latches onto the myeloma cell on BCMA, so it adds specificity to the drug. And then basically, once the antibody latches onto the myeloma cell, it becomes internalized by the myeloma cell, essentially delivering the toxin specifically to the myeloma cell. And so this is how an antibody-drug conjugate works. Belantamethasone was approved by the Food and Drug Administration in 2020. It was an important approval since it was the first BCMA targeted therapy for multiple myeloma. One of the well-known side effects is potentially keratopathy, which is inflammation of the cornea, which needs to be washed when patients are being treated with multiple myeloma. But this is given intravenously, typically at minimum every 3 to 4 weeks. And it's given as an outpatient setting. It's what we call an off-the-shelf therapy, a therapy that can be administered immediately to a patient, like a typical drug. Next slide. Another really, really exciting area of our treatment modality in myeloma is something called chimeric antigen receptor T cells, or CAR-Ts. You've heard a lot about this from the morning presentation. This advance in multiple myeloma. very high response rates, deep response rates, and durations of response patients getting CAR T. This is a little different than other traditional typical drugs. This is essentially a living drug. So basically what happens is the patient will get their T cells or their immune cells collected. These T cells will then be genetically engineered outside of the body to basically not attack infections like bacteria and viruses, but attack the myeloma. And then they'll be expanded, and then essentially they'll be shipped back to the treating site and then basically reinfused into the patient to hopefully wreak havoc on the myeloma. And so this is a little bit more complex, as you can see from the diagram here, in terms of sort of the process that it would entail. Next slide. What's really, really exciting is that there are now 2 CAR T therapies targeting BCMA now approved for multiple myeloma. The first was idacaptogene vicleucel, or the trade name is Abecma, and this was FDA approved in March of 2021. And more recently, as many of you know, in the last month or so, ciltacabtagene autoleucel was FDA approved in February 2022. And this is really exciting because this will hopefully bring access to these novel therapies, access to CAR T therapies more for our patients. Finally, there's bispecific T cell antibodies. So what are these? These are basically 2-armed antibodies where one arm of the antibody binds to a protein expressed on the myeloma. So most commonly in myeloma, we're targeting something called BCMA. There's other sort of tumor proteins that are also being targeted by antibodies like GPRC5D and FCHR5. And essentially the other arm of the antibody targets CD3, which is expressed on T cells. And essentially, a little animation here, there we go. The bispecific T cell antibody is like a matchmaker. It brings the myeloma cell and the T cell in close proximity, but it's the match of death. So essentially the T cell will kill the myeloma cell and hopefully lead to a lot of myeloma cell killing. And so essentially these are how bispecific T cell antibodies work. And so there are a number of bispecific T cell antibodies currently in development, as you can see here: AMG 701, teclistamab, CC93269, Regeneron 5458, Teneobio 383B, and arentinib. And these are all sort of bispecific antibodies, very similar concept. They're all showing strong efficacy in myeloma, 67% overall response rates. And these are an off-the-shelf product, which means that these can be delivered immediately into the clinic. So I think when considering sort of treatment choices with antibody-drug conjugates, CAR Ts, and bispecific T cell antibodies, I think one of the important take-home messages is that it's great that there are options. There's many options for patients. One size doesn't fit all for all patients. And so I think some of the things that we would consider and factors to consider in choosing therapies are listed here. So for instance, advantages of antibody-drug conjugates such as belantamab vedotin, I think one advantage is off the shelf, can be delivered immediately to patients. Since it's relying more on that toxin that's tethered to the antibody, there's less reliance on one's own immune cells to do the work, basically. And so there's less reliance on the endogenous immune system. So in some patients who have received a lot of prior therapy, their immune system may not be as strong. And so perhaps, that's one advantage of drugs like ADCs. It can be given in the community, so there's less complex infrastructure of giving belantamab vedotin, so it can be potentially given in the community. There's really no risk of cytokine release syndrome, which is basically an inflammatory reaction that can occur with some immunotherapies, such as bispecific T cell antibodies and CAR T therapies. It can be potentially given in older patients and frail patients. I think the major potential disadvantage of antibody-drug conjugates is that there is a well-known ocular adverse event or keratopathy that can be associated with belantamab vedotin. And so you just need to be followed very closely with your ophthalmologist or optometrist while you're getting therapy prior to dosing. And generally speaking, there's a lower efficacy as well. And so the overall response rates, at least as a single agent with belantamab vedotin, is about 30% compared to higher efficacy with the CAR Ts and bispecifics. In terms of bispecific T cell antibodies, one advantage is they're off the shelf, so it can be delivered immediately to patients in the clinic, potentially can be administered in the community once they're FDA approved. And there also is strong efficacy with high response rates and depth of response. As I mentioned earlier, the overall response rates in triple class refractory multiple myeloma order is 60 to 70%. The data is still maturing, so we don't really know what the duration of response, or we call that progression-free survival, is at this point yet. And so we'll probably hear more about that in upcoming meetings that report on these antibodies. The drawback is that it's continuous therapy. So typically the bispecific antibodies are dosed weekly or every other week. And so it does require continuous therapy. There is the risk of that cytokine release syndrome, particularly with the first couple of doses of bispecific antibodies. Usually hospital admission is required for the first couple of doses just for CRS monitoring, lasting for about 48 to 72 hours. And it's a little earlier in development than the antibody-drug conjugates and the CAR T therapies. And so we're still awaiting some additional mature efficacy data and also safety data as well. And finally, with CAR Ts, we're seeing very strong efficacy with CAR Ts, both in terms of overall response rates, depth of response, and duration of response with some products. I think what's nice about CAR Ts, it's a one-time dose. So it kind of gives you potentially a treatment-free interval after getting a CAR T infusion. So there is a lot of buildup sort of to get the CAR T infusion, but once you get it, there is potentially a treatment-free interval that you may have. Some of the disadvantages is that potentially it's not the most ideal therapy in patients who are having rapidly progressing disease, because there is a process involved in sort of collecting the T cells, manufacturing the T cells, and reinfusing T cells. So there's usually about a 4 to 6 week delay there. Right now, I think one of the challenges is access. As you may have heard, this will improve. This is, I think, just a temporary thing, but this will improve it. But at least right now, access to CAR T has been a little bit limited due to manufacturing challenges. Sometimes bridging therapy is needed. So in between the time you get your T cells collected to when the T cells are infused, we may need to administer bridging therapy to help keep the myeloma under control. It does require a little bit more of a complex infrastructure. So this is probably treatment that you can't get with your local oncology or community oncology, that needs to be administered in typically a large myeloma treatment center. And they're all, like bispecific antibodies, there are risks potentially for CRS and other immune-related side effects as well. So in summary, take home key points. So there are many options for treatment for multiple myeloma in 2022. And treatment, because of these many options, treatments can and should be individualized based on disease-related factors, treatment-related factors, and patient-related factors. And as I mentioned earlier, the data is rapidly evolving. New treatments are being developed myeloma. There's updates like every 3 to 6 months, probably more frequent than that in myeloma. It's really a full-time job as a myeloma specialist to keep up with this literature. And again, that's our commitment and that's our joy, essentially, to tell you what the next best therapies are for our myeloma patients, to really incorporate the best treatment decisions for you in the clinic. It's really important to consider all classes of myeloma therapy and how to best utilize every weapon in the myeloma arsenal. And so, there are a lot of novel therapies out there for multiple myeloma. I would say that, there's still a role for older treatments as well. So, I think, for instance, alkylating drugs like cyclophosphamide or melphalan oftentimes aren't the shiny new car on the car lot. But there's still a role for these treatments in myeloma. And so really, philosophically, I'm sort of speaking strategically in the clinic, how can we best utilize every treatment, every weapon in the arsenal against multiple myeloma to really have the best outcome possible? As a myeloma patient, be proactive, become a myeloma expert yourself. The Myeloma Crowd is a great organization, has a great website that provides educational material for patients. Empower yourself to learn more about the myeloma and really, feel empowered to ask your doctor about present and future treatment options for their multiple myeloma with your clinic team. And really, the future is bright. So I mentioned a lot of progress in myeloma over the last 10 to 15 years. Nothing is slowing down about this progress. And so it continues to accelerate. It's a really, really exciting time in the myeloma field in terms of research. The treatments in 2022 are going to be different in 2027, 2032, 2037. These are all relevant time points for newly diagnosed myeloma patients. The treatments are going to vastly evolve. And so, it's a really, really exciting time, and progress continues to be made. So thank you very much. I'd be happy to answer any questions later on, and thank you for your attention.